Welcome all to this parallel session. I'm Outi Ruishalme, and I work in the Mieli Mental Health Finland, and my responsibility is on our crisis work, crisis help activities, and I tell about them a little later because one of our presenters had to cancel, so I tell you a few words about our work and about the mental health promotion we are doing and would like to do more. But first we have here Eleanor Mittendorfer-Rutsch from Karolinska Institute from Stockholm, Sweden. And she will talk about inequalities in suicides globally, so to say, isn't it so? Welcome warmly.
Thank you very much, and thank you for the invitation. It's really lovely to be here. So I would like to start with, before we go into the specific inequalities of suicide, I want to revisit the concept which we have today on the suicidal process. So how we see it today, and this is also important to understand why there are inequalities in suicidal behavior, is that it very often starts with a subjective, not tolerable situation, a crisis. This can be, for example, a psychiatric illness. Then may lead to depressive thinking and hopelessness, and to something which we often call psychic pain. Hopelessness is a very strong driver in this process and has been identified as a very strong risk factor for suicidal behavior. The pathway then to suicide is very often characterized through a tunnel thinking. No other coping strategies available. The only solution you see to solve this problem is suicide. So let's keep that in mind when we discuss now the inequalities in suicide. We have different models in suicidology. One of the most often cited model is the stress diathesis model, which is describing the suicidal process as an interaction between the diathesis, a vulnerability to suicidal behavior, and stress factors. So there are a number of different risk factors, which I will not touch upon all of them today, but I want to highlight some of them which are interesting for us in the light of the pandemic. And I will tell you later on why. So let's look at the stress factors, for these have been possibly changing during the pandemic. And let's kind of cluster them, even if this is not easy to do, in biological, psychological, and social factors. So from the biological side, mental disorders, we all know about that they are strong risk factors for suicidal behavior. Psychological negative life events might, of course, have happened during the pandemic, stressful situation, and an emotional crisis. And with regard to the social factors, let's talk about migration, migrants, a very risk group for suicidal behavior and mental disorders. And of course, social and economic adversity, also something which is strongly related to suicidal behavior and also characterizes the inequalities. And particularly here, changes in this socioeconomic status and loss of job, for example. So let's look at the international variation and the inequality between countries. This is the latest data from the WHO Global Health Estimates from 2016. And you see that, of course, it's not only the individual factors which are talked about, but also a number of structural factors which are behind these differences and the international differences. And when we look at the Nordic countries, you see that there are not very large differences between our countries. Denmark and Norway have somewhat lower suicide rates per 100,000 than the remaining Nordic countries have. An important risk factor for suicidal behavior, in particular for suicide, is male gender. So let's also have a look at the male-female ratio of age standardized suicide rates in 2016. Again, this is WHO data. There we see differences also between the Nordic countries. We see that the male-female ratio is higher in Finland than it is in Norway, Sweden, and Denmark, and it is highest in Iceland. Actually, there the male-female ratio is more than 4. So this is important also, of course, for reducing the inequalities and also for suicide prevention in these specific countries when specific suicide prevention strategies are considered. Let's quickly talk about the international COVID-19 suicide prevention research collaboration, which is now including approximately 45 countries, even more coming and joining the group. I joined this group in early 2020. Actually, it was started immediately after the first reports of the pandemic. A very active group, wonderful to be part of that. David Gunnell is updating us with the latest research findings nearly every month, and we have continuous seminars. What we did here under the lead of Jane Perkis is to make a study on suicide in 21 regions and countries. You see them here. Sweden could not be part of the first paper because we didn't have suicide data up until July 2020. But I've recently sent the data from Sweden to the research group because we will continue this work. So the first study came out in Lancet Psychiatry. And there we found no evidence of a significant increase in risk of suicide since the pandemic in any of these 21 countries or regions. The next paper, which we are currently working on, will have more countries included, as I just said, and will also look at gender, age, and methods differences. So we are very much looking forward to see the results there. This is, of course, a very positive news. When we look at the data for suicide rates per 100,000 in the 5 Nordic countries, which we are talking about today and yesterday, we can see that, and this is data from the HFA database, we can see that in several countries, the suicide rates have been decreasing to an extent that the gap between the different suicide rates in these 5 countries is now much smaller than it was in 1980. I've been also talking with colleagues in all 5 countries. In no country of these 5 Nordic countries, there is an increase in suicide rates during 2020, which is, of course, also very favored. This data from 2020 is not in the HFA database yet, which is a WHO-driven database. So what were our explanations when we discussed the findings in the Lancet Psychiatry paper? Well, for the non-existent increase in suicide rates. Well, what we discussed a lot is, of course, that in many countries, social insurance regulations were started. And of course, this has buffered the effect, a potential negative effect. There were fiscal support initiatives, very important also to kind of counteract potential negative effects of unemployment. A sense of togetherness may be, of course, difficult to study, but people who have been excluded before and felt themselves excluded might have had the feeling that they are more included in the society because everybody else is actually was sitting in the same boat. And the healthcare system reacted very quickly to these extreme challenges. But this is not everywhere the same. So there are reports now coming from, for example, Japan, finding, you can see that on the right-hand slide, a quite obvious suicide increase, a trend of suicide deaths in Japan, particularly in young women. We have also reports from Hungary. So it is not similar to all the countries. Here in Japan, they have been following that to a temporal vicinity to celebrity suicides, which obviously have not been covered by the media in a responsible way. And these women were predominantly in socio-economical adversities. So important to continue monitoring. That's what we also discussed in the International COVID-19 Suicide Prevention Collaboration. And of course, also to react immediately if these changes should occur even in other countries. So what does the additional evidence tells us? Now there are more and more systematic reviews coming up. Suicidal behavior during the COVID-19 pandemic, for example, a recent published meta-analysis of 54 studies. The main findings show that there are increased event rates for suicide ideation, 10.8%, suicide attempt, 4.7%, and self-harm, 9.6% during the COVID-19 pandemic, when compared to event rates from pre-pandemic studies. So we all know that suicide attempt, for example, is the strongest risk factor for suicide. So it is important to look at these studies carefully. What is also very important, as I've been following the literature now since the pandemic started, in the beginning, they were actually quite poorly performed studies. So we really have to make sure that we do well-performed studies and also have good, well-performed and serious conclusions of studies. Here it is important to mention that several of these studies are cross-sectional and self-reported. So we need more evidence, of course, but this is at least what we have now. What we know also from with regard to depressive symptoms and anxiety, this is a recent also meta-analysis, as you see here with regard to that. So symptoms of anxiety and depression were also increased in the general population during the early phase of the pandemic. It's important to remind ourselves that, I mean, the publications which are coming up now, of course, it takes some time to publish, predominantly looking at the first months of the pandemic. So, of course, we have to wait to make more firm conclusions for several other months. But, of course, as you see here, there is some variation. Some studies show even lower risk of symptoms of anxiety and depression, but the meta-analysis shows that taken together, it has been increased in the general population. So again, back to our topic on the inequalities, which factors and which groups have been identified with regard to depressive and anxiety symptoms, which of course is another measure of mental ill health, but I mean, it's also related to suicidal behavior. In part also in the studies on suicide and in part also in the studies on suicide attempt. It is individuals with mental disorders, of course, socioeconomic adversities, young people and migrants. These groups I would like to particularly focus on now in the next minutes, discussing about potential strategies to reduce these inequalities. Mental disorders first. So mental disorders are, if you look at different review studies, approximately 60 to 98% of people who die by suicide have a mental disorder, predominantly mood disorders, substance abuse disorders, schizophrenia, and personality disorders. We know from a couple of studies that suicide prevention within the healthcare system works, both medication and also psychotherapy. But what, of course, happened during the pandemic and what we have to be very careful about and monitoring also and seeing the potential consequences is that the healthcare system, of course, had to respond to this pandemic, and mental health care services were to some extent affected. So the WHO published a report on the impact of COVID-19 on mental, neurological, and substance use services with the following key messages. So it is recognized by countries as an integral component of their COVID-19 response. So all the services related to mental and neurological and substance abuse services, which is, of course, very good news. But there are also disruptions of essential services reported in many countries. No country had kind of full closure, but many countries were suffering. Good news is that there were lessons learned very quickly. So the systems were changed also, and different solutions were set in place, particularly telemedicine. So what did the respondents to this WHO survey mainly indicate is that telemedicine, for example, was indicated by 70% of all respondents, and these are national representatives of these countries. 67% reported that they initiated helplines for mental health and psychosocial support. and 65% special measures for infection prevention and control in mental health services. And you see the list with all other initiatives which were established. But of course, there is a digital divide for a number of people, particularly elderly people, for example, but also other people. And we all see that the fourth wave is hitting many countries in Europe now very drastically. Hope that most of our Nordic countries will not kind of experience the same drastic increase in infection rates. But of course, this has to be continued. An establishment has to be continued and also improved in order to provide good mental health care for people with mental disorders. Let's talk about economic adversity. We know that this is strongly related to suicidal behavior. I want to share with you one paper which kind of maybe tells us also the different pathways where we have to be very careful in the future. It's a paper published in the BMJ on the impact of the 2008 global economic crisis on suicide, time trends in 54 countries. Here on this slide, you see that, of course, related to 2007, there was an enormous increase in unemployment rate and a stable GDP development per capita. This is an average of all these 54 countries. What they found is that the suicide rate in the 27 European countries, because this was a global study, increased in men with 4.2% in 2009 compared to the levels expected from 2000 to 2007, particularly in young men, 15 to 24 years, and there it was an 11.7% increase. So these rises in men were associated with the levels of unemployment, particularly in countries with low unemployment rates before the pandemic. So important to kind of draw also some lessons from these earlier studies. Of course, this is an association study. Out of kind of natural reasons, it cannot be a randomized controlled trial, but still it is important to be observant and also kind of to keep, as I see that, to keep our fiscal support measures and the social insurance measures even in the years to come, because it is not kind of sure that we will not have a rise in suicide rates, particularly in men, as I showed you, which were a specific risk group in the years to come. Youth suicide, another topic, and a specific risk group, which we heard a lot about today in the plenary this morning. We know that suicide is among the top 4 causes of death in this age group from 15 to 29. In women, it is actually the 3rd cause of death, and in men, it is the 4th cause of death. Again, this is WHO data. What we see in several countries now, and I'm giving you here some examples, is a drastic increase, for example, in temporal trends in suicide attempt among children in the decade before and during the COVID-19 pandemic in Paris, for example, at the left-hand slide. And what we see also on the right-hand slide, increases in parasuicide, again in children during lockdown measures. Some examples, of course, this is not universal, but it is an area which we have to be very, very careful. If I look at, for example, and discuss the figures in Sweden, there we have seen inpatient specialist outpatient care treatment due to suicide attempt rising since the 1990s, with some leveling off during the last years, but still they are very high levels. We have to be very, very careful that this is not even increasing further. This is a very vulnerable group, and we have, of course, to start with and continue with tailor-made suicide prevention and suicide attempt prevention strategies for this particularly vulnerable group. I'm not aware of the statistics so well in the other Nordic countries. I hope it's not that development as we see in Sweden. And we know quite a lot about suicide prevention in this age group. So we just have to establish that to decrease this vulnerability. Migration, this is the last factor which I want to focus on. We might not be so much aware of that, but it's actually 82.4 million people forcibly displaced today. This is, in the Second World War, between approximately 1939 till 1950, some years afterwards, there were approximately 30 million refugees. This is nearly 3 times as much. So we are living in an exceptional time right now. 26 million people worldwide refugees. Even if we talk a lot in European countries of migrants and migration and also kind of the social political situation and problems associated with it, it's actually only 6% of the world's forcibly displaced people hosted in European countries. So countries like the Middle East and North Africa and other African countries have an incomparably much larger situation and problem to tackle with. We know that mental disorders, which are strong risk factors for suicidal behavior, are very prevalent in migrants, particularly refugees. The most prevalent mental disorders in refugees are post-traumatic stress disorders. Prevalence estimates for 10%. This is based on a review of different studies. Depression 5% and generalized anxiety 4%. These disorders are, of course, very often comorbid. Refugees resettled in Western countries could be up to 10 times more likely to have PTSD than their age-matched general population's controls. And we know that these disorders, particularly PTSD, is also very strongly related to suicidal behavior. So a group where we have to be very careful. Despite these higher prevalence rates, we also know from a latest report from the Council of Europe that the access and quality of healthcare from migrants is decreased. This is showing you an access on and a graph on the x-axis. It is the degree of quality, and on the y-axis the degree of access to care in migrants. You see here a number of countries in Eastern European countries with poor access and poor quality of healthcare for migrants, and here with good quality and access, even if with regard to varying degrees. The Nordic countries are all in this circle. So what did we do? We did several studies in Sweden in order, this was before the pandemic, so we really have to kind of continue with this research and see how this group of individuals have been experiencing the pandemic with regard to also suicide rates. What we did in 2017 is to look at the suicide rates per 100,000 unaccompanied asylum-seeking minors in the total population in Sweden. We looked at a group of people between 10 and 21 years. What you see here is first the Swedish population and then the unaccompanied minors seeking asylum. You see that the suicide rates were per 100,000 were 6.1 for the Swedish population and 51.2 for the unaccompanied minors. This is a suicide rate which is kind of more or less unseen. It's extremely high in this age group. You know that suicide risk is increasing with age. At that time, we were really bombarded with reports, of course, from journalists, and of course, this was discussed very, very widely. Before the period before this report was conducted was more or less characterized by everyday new media reports of suicides and unaccompanied minors. This happened after 2015. We are looking at the figures for 2017. So of course we said that maybe this is something which only happened in Sweden because many of the social services have had were very challenged during that time. So we tried to look at that in Denmark, and this is a work in progress, so it's not published yet, together with Annette Erlingsen and her team. And what you see here is also for unaccompanied refugee minors and compared to the asylum seekers, compared to the general population. And you see that for the unaccompanied refugees, it's a 6-fold increase. So that we are looking at incidence rate ratios in this group, and a nearly 7-fold higher rate ratios in all asylum seekers. So it's the same in Denmark as well. And here we are looking at suicide attempt and not suicide. So obviously we have to be very, very careful with this group, and they have been most likely very affected during the pandemic also. What happens with refugees who have a residence permit? Here you see that findings from Sweden and Norway. This is recently published. What you see here is, and what indicated by the circle, is that the refugees with a residence permit had a lower risk compared to the general population, which you see indicated with 1 as the reference group with the dotted line. It varies somewhat across countries, but it is very consistent across different nations with regard to suicide, Sweden and Norway. So this group seems to be, at least to some extent, protected. We have been discussing this in the light of these refugees mainly coming from Muslim-dominated countries, where the religion more or less kind of prevents people from suicidal acts. So I think the important measures which we have to consider, and also to kind of reduce these inequalities in suicide in the Nordic countries, also in the wake of the pandemic and following the pandemic, whenever it will be finished. Social insurance networks, extremely important in order to kind of limit and social adversities and give people also decent socioeconomic backgrounds. Fiscal support initiatives, likewise, it is important to continue that, even if our countries have been excellent in establishing that directly in the beginning. Suicide prevention strategies, of course, considering specific risk groups, and I've been discussing which risk groups I think we should focus on. Healthcare preparedness, we have to continue working a lot with telemedicine and expanding this. It is very important to have well-performed studies. I don't know if you follow the literature very carefully, but lately there has been a paper in The Lancet published showing different suicide rates colored in different countries. When you actually looked at the paper, you found out that these estimates were not based on empirical findings, but on modulations of findings. So for example, for anxiety, there was no empirical data, neither before nor during the pandemic. In Sweden, it was just no empirical data. It was modeled with other data. This is a very good example of how findings kind of establish our thoughts about this. So we have to be very careful. If there is not an avalanche of suicide or an avalanche of mental disorders in the population, then we have to be careful not to have increased the community anxiety with regard to that. There was a huge newspaper report on this in Dagens Nyheter, which is one of the main Swedish newspapers, not mentioning that this was not based on empirical data and saying that we have huge problem in Sweden with mental health after the pandemic. So we have to be careful with having good studies, drawing correct conclusions, and also the journalists really looking at the findings, what is there and what lessons can we learn from that. And with regard to this, I also want to mention the responsive media reporting in this international COVID-19 suicide prevention network. We have on our website something which most of you in the room and maybe also those who listen know very well. So it is important to remove references to methods of suicide where possible, avoid simplistic explanations of suicide, avoid sensational language, for example, crisis and spike, take care when describing suicide and youth, and remind people that suicide is preventable. Thank you very much.
Thank you very much for your very interesting presentation. Are there any questions? Christian.
Thank you for an excellent and very clear presentation. I have two questions. One is regarding whether we are too early to judge the suicide implications of the COVID crisis, because suicide is a result of a long process, and is it so that perhaps we are still to see a possible rise in suicides? And the other question is regarding the alarming figures you showed about suicide attempts in children. And what interventions would you recommend? Because that's an area we have not developed yet very well in Finland.
Yes, to the first point, my personal opinion, and I think it's also supported in this international COVID-19 suicide prevention research group, is that we should not be too early to say the danger is over. This is also what we focused very much in the Lancet Psychiatry paper, is that kind of continuous monitoring is necessary in all countries And we are continuing our research, and I'm also involved in a EU-funded project where we will look and compare the suicide rates and also specific risk groups in Italy, Spain, and Sweden, because they have been differently affected by the pandemic. So yes, I think we should be very careful. We should monitor this, and we should look at specific groups. There might be differences in different groups, and of course, be glad that there are not kind of strong increases, but they are not very strong decreases either. So, I mean, we have still an issue with suicide, right? I mean, it's still 3 times the accidents, right? So, and to your second question, yes, I think this is something which we have to be very careful about. I mean, there are different approaches there. I mean, of course, we have the approach within the healthcare system. There are different studies with regard to which medication work and which psychotherapy works. And there it's predominantly CBT and also dialectical behavior therapy. And but I mean, of course, in addition to that, we have a much broader perspective also with regard to public health measures, and this is of course restricted to access to means, which might be also specific in different youth groups. And then there are a number of studies which show us also effects on screening in schools. Of course, it's a little bit tricky now with the pandemic if people are not in schools, but in the long run, we have seen at least very good examples for screenings, and then of course referring to a specific treatment, but also other initiatives within schools where talking together about programs, looking together at films and then discussing them, and also gatekeeper trainings, for example, kind of teachers which have been trained to kind of recognize mental ill health in their pupils, and then try to kind of also collaborate with healthcare services. So we know quite a lot in this respect, and I definitely can share quite a lot of literature with you with regard to that.
Any other questions? Are there some questions seen in the chat? No. Okay. Well, perhaps we go on. Thank you very much.